Then, ladies and gentlemen, first of all, I'd like to thank the organizing committee who has already invited me to this very beautiful virtual conference of JSFI 2020. On these occasions, I'd like to present the experience from Indonesia in developing fertility preservation services. So these presentations will be delivered from patient and health provider perspective to clinical practice about the early development of fertility preservation in Indonesia. The outline of my topics is: the first is challenge and opportunity on fertility observations. Second, our evidence in research. And then the last is what next step to Indonesian fertility services. As we know, about fertility preservation in women can be performed in urgent condition, or we can delay some time for doing fertility preservations because of gonadotoxic cancer treatments. Yeah, we can divide it, the policy, the strategy into urgent fertility preservation and delayed fertility preservations. If in urgent fertility preservation, there's several procedures that we can done, including ovarian tissue cryopreservations, random start IVF, or doing in vitro maturation procedures. And if we can delay sometimes fertility preservation, ovarian stimulation followed by embryo cryopreservation or oocyte cryopreservation maybe is a good choice for we over to our patients for doing fertility preservations. If we look this data that cancer survivors, most of them actually really want to become parents after they're suffering from cancer treatment. That experiencing cancer as a child or young adult often strengthen the value survivor place on being parents. And it was strengthened by the large study by Green 2002 that did not identify adverse pregnancy outcome for female survivors that was treated with most chemotherapeutic agents. And this is our data in Indonesia. Among Indonesian cancer patients' perspective, at least 52% of them desire to have or to add more children after they are living from the cancer. And the next, this is the knowledge of fertility observations. The 88% unfortunately did not know well about fertility preservations, that the factors that influence the decisions to have fertility preservation services among patients are: the first is knowledge, the second cost, and the last is social environment. If we look the attitude toward fertility observations, most of them, 72% are agree that reproductive function is one of important things to consider in cancer treatment. And 54% agree fertility preservation is high priority to discuss. But however, 82% also agree that primary cancer is more important than fertility preservation. It seems like contradictory statement between number 2 and number 3. But they are unwilling, of course, to receive a less effective cancer treatment, even in order to preserve their fertility. And the other data also coming from healthcare providers who treating patients with the cancer. This is a pilot study that performed in our center in 2018. And if it looks also, among ONG, among ONG, 86% they are knowledgeable about fertility preservation for cancer patients. And this is several fertility preservation that they are knowing well. Mostly, this is the very knowledgeable. Mostly, it's only GNS agonists, yes, and then knowledgeable about sperm, oocyte, embryo cryopreservation, and also ovarian tissue and testicular tissue cryopreservations. And some of them also not at all knowledgeable about this kind of surfaces that is very important for our cancer survivor patients. What is the barrier to initiating the discussion about fertility observation? Number one, this is really the most consideration among health providers in Indonesia is the poor success rate of fertility preservation option. And maybe they didn't know, and also patient could not afford, considering the cost, poor patient prognosis, and the lack of ONG knowledge as well, and lack of fertility preservation services in our country. This is why, this is how the barrier. And how actually the development of ovarian tissue cryopreservation in Indonesia. The first, this is in 2006, 2007, when I was study in Hyogo College of Medicine in collaboration with Professor Akiko Hasigawa. We did the ovarian tissue vitrification and in vitro culture of follicle until puppet. And then this is continue in Jakarta. Fertility preservation underwent in patient with endometriosis, and also continue with the 13 patient with breast cancer and cervical cancer. Mostly we do ovarian tissue vitrification, and the last also we are trying to develop the preantral vitrification technique. This is some picture when I studied in Japan in Hyogo College of Medicine. This is Professor Koji Koyama, and then this is Professor Shinzo Isojima, and this is Professor Akiko Hasegawa. And also I learned in Namba. Yeah, this is the picture how we did in vitro culture of follicles in 2006 in Hyogo College of Medicines. We start the in vitro culture among secondary or prenatal follicles, and then doing in vitro growth, and then in vitro maturation, and we did in vitro fertilizations. This one is continued by my junior, Dr. Mila. She is now graduated for a PhD from Edinburgh University under Evelyn Telfer supervisor. And then this is when she was in St. Mariana University with Dr. Kemal, and this is Professor Nao Suzuki. They did also in vitro culture of follicles, exposing by some chemotherapeutic agent, and then they are measuring the athletic amount preantral follicle that was growth. This is one of the study that was published 2014, ovarian tissue cryopreservation that we did among endometriosis patients. And I think it was succeeded. Most of the follicles were survived after vitrified. Consists of primary, secondary follicles that are coming from endometriosis patient. This is the picture. The primary follicle and primary follicle from fresh ovarian tissue, and then this is the secondary follicle and intact follicle from warm vitrified ovaries. And the next also we do the in vitro culture of follicles. After we do the follicle isolations, and then we are measuring the pro and anti-apoptosis gene, and then doing the in vitro culture of follicles. You can see here how we did the ovarian tissue section by cryo tissue. This is after vitrifications. And then yes, this is the back expression and BCL2 expression. This is fast ligand and caspestry expressions among fresh tissue. No significant difference between fresh and then with fresh and tau warm vitrified ovary, the expression gene pro and anti-apoptosis gene. And also this is isolated preantral follicles that we do by combination of librase, DNAC, collagenase, and DNAC. We compare all the procedures doing only by librase plus DNAC or collagenase plus DNAC. and no significant difference. This is parental follicles after vivification in terms of morphology in the primary follicles, primary, secondary, and oocyte. It was proved that doing vivification of parental follicles is still safe. How was the perspective of Turner syndrome about fertility preservation? We did a depth interview among 20 Turner syndrome patients with their parents about the future of reproductions, and most of them have better knowledge about reproduction. In the support group, this is the non-support groups, no significant difference that they know well. There is a fertility impairment in Turner syndrome patients, and also this is they know the possibility of having children. This is also the knowledge of them on the two groups. And then the concerns, the major concern in patients with Turner syndrome is fertility issue. There's no difference between support group and non-support group, and also about fertility and willingness to have fertility treatment. This is also very important that we should think about fertility preservation in Turner syndrome patient or in patient with high risk to suffering from primary ovarian insufficiency. This is the milestone of developing fertility preservation in our country. That we want to determine how the ovarian reserve between cancer patient and non-cancer patient like Turner syndrome, and we'd like to see whether the ovarian reserve determined by cancer stage, type of cancer, and then we do also the ovarian tissue freezing in vitro culture and developing guidelines and policy for the countries. This is one of our team, Dr. Mila, who did the training with Professor Sherman Silber in San Luis, Mississippi, and also with Dr. Kemal, training for ovarian tissue transplantation using the bovine ovaries. And this is the latest our publication about AMH comparison between cancer and non-cancer patients among 44 female patients that we did the study between 2015 to 2016, and then we are comparing the MS level of 44 cancer patients versus 44 healthy controls. If you look this one, the cancer patient really have lower significantly serum AMH compared to non-cancer patients. And if we put into our calculator, Indonesian calculator outside, this is our calculator, that we can differentiate biological aging with chronological age. And if we put, this is the data, this is our cancer patient with MS level on average 1.1. This is control 3.9. It looks that the cancer patient has biological age 10 years older than the non-cancer patient. Yeah, it can be caused by the cancer itself. If you look this one, mostly the group, the patients coming from non-gynecological cancer and gynecological cancer, but if you compare both of group, it's not significantly different. But this is a very interesting that the cancer might also affect the ovarian reserve. So very, very important. Before we offering ovarian tissue preservation, we should check first how was their ovarian reserve, so we can do the service better with better quality to our cancer patients. This is the guidelines of Indonesian Fertility Guard. Yes, this is our center. Sometimes we can offering them doing the procedure in their hospital and then specimen transported, or even the process, the patient sent to our hospital, and then all the process was done in our hospital. It's very important in Indonesia because we are very huge countries. At least we need 2 or 3 center, excellent center that doing or offering the fertility preservation services. So as take-home messages, the first fertility preservation in Indonesia has been started in very limited number. And ovarian tissue vivification in our country has good survival and viability. And based on our evidence, endometrioma and primary ovarian insufficiency are good candidates for doing fertility observation. Isolated parental follicle vitrification should be developed further. This is considered of there is a micrometastasis in ovarian tissue among hematologic malignancy patients. And the last, to develop fertility preservation, we need transdisciplinary collaboration, good networking, and benchmarking. I think this is my presentation. Thank you very much for your kind attention. Domo arigatou gozaimasu.